Good morning, everybody. So what I'm going to do over the next 30 minutes or so is going to talk about a very important topic, that's rejection and tolerance. Things have evolved over the last 2 decades in transplantation, and I'm going to see where we are heading now. So basically, I'm going to talk about liver as an immune organ, basics of rejection and tolerance, what is operational tolerance protocol, T-regs in liver transplant recipient, and then we'll talk about some future directions as well. So human liver transplantation, first performed successfully in 1963, was until 1980s considered to be an experimental procedure with very poor outcomes actually. Then advances in surgical technique, organ preservation, immunosuppressive drug therapy led to markedly improved outcome, both patient and graft survival as well. But then over the time we have seen that initially the patient does survive, but the long-term results are hampered with side effects of immunosuppressive therapy, especially the risk of infection, cardiovascular diseases, recurrent diseases, and certain types of cancer as well. So basically at this stage, when we see transplantation, it is a balance between anti-rejection drugs and rejection. This is the main area of concern which need to evolve, and this is now considered to be a holy grail of transplantation. So what has happened, what we have seen over the last 2 decades is many liver transplant recipients tolerate reduced doses of immunosuppression. This is actually unique for liver. It doesn't happen with other organs. And approximately 20 to 40% of stable graft recipients can be withdrawn from immunosuppression without rejection as well. And those recipients, even if they experience episodes of rejection, can be tackled by standard care of immunosuppressive therapy, and almost invariably they will not have a graft loss. And in rodents, human liver transplant reduce alloimmune injury to kidney and heart grafts. So if you do a simultaneous transplant with liver along with heart or kidney, then the survival of those kidney and heart grafts is much better than isolated heart or kidney transplant. So that just shows that the liver, how much immune potential liver have, and also the tolerogenicity of the human liver in terms of protecting other organs as well. So that's what we are heading for, that if we understand mechanisms of rejection and tolerance, then actually we can achieve much better survival and much longer survival without the side effects of anti-immunosuppressive therapy as well. So when we see liver is a unique and immunologically privileged organ because of the size of the liver, and it's got a dual blood supply as well. It's got an immense ability to regenerate, which we have seen with live donor liver transplantation. That operation is based on basically because the liver has got immense ability to regenerate. Then the capacity of Kupffer cells to remove immune complexes and activated complement. This actually happens in the normal process as well, because all the portal flow which is taken up by the liver, it removes lots of immune complexes and activated complement as well. Then one of the things which is there with the liver endothelial cells is there is a low expression of HLA class 2 antigen. So there is a low immune reaction within the liver as well, and that is one of the baseline, because that's why we don't get AMR, and also the tolerance happens in the liver as well. And liver is always under an immunological threat, as I said, because of the portal flow going into the liver, and liver has to remove and identify lots of what is needed and what is not needed, and that's why there is a lot of tolericity within the liver in terms of throwing back into the systemic circulation. And liver has a central role in systemic innate immunity as well. So this diagram, I think everybody is aware of this cartoon. Hepatocytes, then the endothelial lining cells, then the natural killer cells, natural killer T cells, Kupffer cells. So when the blood flows through the sinusoidal epithelium, there is a lot of immunological reaction which happens normally within the liver, and all these cells actually clear out a lot of immunological burden which comes through the portal, through the bile ducts, through the portal vein and hepatic artery as well. And the other key players are dendritic cell, natural killer cells, natural killer T cells, inflammatory cytokines, complement components and acute phase proteins and chemokines. And all this plays actually critical role in immunogenicity within the liver as well. So when we see the various pathways which has been described in terms of immunogenicity of the liver and how liver becomes tolerant, the key players are dendritic cells, Cooper cells, natural killer cells, hepatic stellate cells, and the most important are the T-reg cells, which I'm going to talk in detail. So the two most important player in this is dendritic cell and T-reg cells. So dendritic cells, they had very immense capacity in terms of basically low surface levels of MHC class 2 and T cell co-stimulatory molecules. So the liver conventional myeloid dendritic cell express high level of CD39 and endonucleotidase that hydrolyzes extracellular ATPs into AMPs, which in turn degrades to adenosine, a potent anti-inflammatory molecule, by another nucleotidase, that is CD73. And then the locally produced IL-10 and transforming growth factor beta inhibit liver myeloid dendritic cell maturation, which is what is considered to be an important pathway for tolerogenicity of the liver. And then negatively regulate the T stimulatory cells and production of IL-2 production by promoting immunosuppressive effect of the IL-10 secretion as well. So there is negative regulation of tool-like receptors response and subsequent dendritic cell activation owing to DNX activating proteins and triggering receptor expressed on myeloid cells as well and interleukin cells. So this is how basically there is suppression of myeloid dendritic cells, and it leads to suppression of the T-reg cells as well, and that's where the tolerogenic capacity comes in. So when we see T-reg cell, the T-reg cells are very important. T-reg cell control the immune response to self and foreign particles and play a key role in immune homeostasis. T-regs are T cells which expresses CD4 and CD25 and nuclear transcription factor FOXP3. This is very important. FOXP3 is essential for maintaining suppression of immune system and defining features of T-regs. T-regs exerts its immunosuppressive activity through suppressive cytokines including TGF-beta and IL-10, adenosine, and regulatory activity through pro-inflammatory cytokines, mainly IL-17 and INF-alpha. So human T-reg cells are further divided into subpopulation based on their expression of level of FOXP3 and CD45RA. They can be naive or resting CD45RA positive FOXP3 low, or they can be effector CD45RA negative FOXP3 high, which are basically the cytotoxic T-regs, and they can be cytokine producing CD45RA negative FOXP3 low as well, and this also maintains the immunity within the liver as well. The relative increased frequency of effector T cell compared to T-regs may shift the balance towards allograft destruction by rejection. So an immunosuppressive medication causes decrease in effector T cell, but simultaneously they also cause decrease in the frequency of T-regs in the peripheral blood. And it has been shown that if you have maintenance of T-regs, then both the episodes of rejection may be low, and actually in the long term there may be good tolerogenicity as well. And then I'll show you how T-regs are now being used as in clinical practice in order to increase the tolerogenicity. So this is just a cartoon showing how the T-regs actually get activated from naive cell to T-reg cell, and then because of secretions of IL-10 and TGF-beta, they suppress the effector T cells, which in order basically will decrease the cytotoxicity of and will basically act as an immunosuppressive as well. They also activate the B-reg cell, which actually inhibit the monocyte and dendritic cells as well, and that leads to tolerogenicity as well. So coming to rejection, before we understand tolerance much better, we need to understand rejection within the liver, because liver as an organ is very different from other organs in terms of rejection. So acute cellular rejection is common in liver. It is called as TCMR, T cell mediated rejection. It can happen early within 6 months, which is direct by direct antigen presentation, or it can be late acute rejection, that is made after 6 months by indirect antigen presentation. Then it can be acute humoral rejection, that is called as AMR, which is very less in liver. Actually, it's a rarity, to be honest, but increasingly now, because as we understand even more pathways, it has been recognized that AMR may actually happen at a low intensity in liver over a long period of time as well. Then chronic rejection, again, it happens only 5% of the patient, and it is through indirect alloantigen presentation. So coming to hyperacute rejection, it happens within few minutes to few hours, and it is mediated by pre-existing antibodies specific to graft antigen, either ABO type antigen or HLA antigens. These different antigens can activate the complement of the host and lead to damage of the endothelial cell. The process is often accompanied with platelet activation and results in thrombosis and vascular occlusion. In addition, the massive recruitment of neutrophils occurs as well, followed by rapid inflammation and after transplantation, which is characterized by pathological changes as well. So this rejection is very rare in liver, and that's because of the immune potential of the liver, and because the liver is such a huge organ and it can deal with so much of antigenic load, that this actually rarely happens. But it is not like it is not known, it can still happen. We had 2 cases like this, and as I said, there is increased recognition that even this can happen in the longer term as a slow process, and if the immunosuppression is minimized to a too low level, then this can lead to chronic rejections as well. So there is marked acinar disarray, focal areas of coagulative necrosis on histology, disintegration of the portal tracts. There is minimal inflammation, but there is severe disruption of sinusoidal endothelial cells. And this is actually, it is difficult to identify histologically. Only one of the markers, that is C4D positivity, is considered to be a hallmark of this AMR rejection. But still, histology sometimes can be difficult to differentiate in hyperacute rejections. So this I have already emphasized that AMR is rare. Why it is rare? Because of the size of the liver. Then Cooper cell DSA clearance activated complement platelet aggregates, and form soluble donor HLA class 1 and anti-class 1 DSA, which basically leads to liver tolerogenicity. Variable hepatic versus constant kidney and heart microvascular class 2 expression, that is MHC class 2, is very less expressed within the liver, and that's why AMR is actually rare in the liver. And then Cooper cell and liver sinusoidal endothelial cells, FC receptor expression and phagocytic activity, again, which lead to clearance of lot of immune complexes. Then hepatic regenerative capacity, and suspected in unexplained graft function, that is ABO incompatible liver transplant. Again, AMR can happen in ABO incompatible liver transplant, which is more commonly known in liver in terms of AMR rejection. So one of this big problem of AMR which happens in kidney is not there in the liver. So that's one understanding about rejection within the liver. So we don't need to be aggressive in terms of initial immunosuppression in the liver. So we've seen, like in live donor liver transplantation, we can go down on immunosuppression quite remarkably. They don't need an induction type of immunosuppression, and that's very different from when we take kidney, where AMR is very common, and they need induction immunosuppression to start with. So that's one of the start point in terms of liver transplantation, that you don't need heavy immunosuppression to start with. Then coming to acute rejection in liver transplant, it commonly happens between 5 to 30 days. 60% of all these episodes will occur within first weeks, and when it happens within the first 6 months, it is called as early acute rejection. When it is more than 6 months, then it is called as late acute rejection. There is somewhat immunologically they are a bit different, but still they are treated in the same way. As the time from transplantation increases, the rejection episodes actually become less and less common. It is also known that when you have an episode of acute rejection in liver, you might have a better graft and patient survival. The reason for this are not very well known, but this is well documented in the literature, and a single episode of treatable acute rejection actually leads to better long-term graft and patient survival. Then patient who survive more than 1 year after transplantation, rejection occurs less than 30%. Actually, it is not a worry as such, unless the patient stops taking immunosuppression and those things happen. Otherwise, rejections, most of the time rejection will be treatable. So acute rejection happens when you have inadequately immunosuppressed patient. Pediatric recipients, because a lot of activity happens when they are growing, so again they are at risk of developing rejection. Female patient, again for unknown reasons, they are at more prone of developing rejections. And autoimmune disorders, because of the inherent disease type in those patients, so they are at increased risk of developing acute rejections as well. So this is humoral or cellular mechanisms are involved. Antibodies can injure the graft by activating complement and mononuclear cells with Fc receptor that recognize alloantigen on endothelial cells, resulting in vasculitis. Then cytotoxic T cells will recognize alloantigens on an antigen presenting cell by direct presentation on the donor tissue and endothelial cells, which promotes apoptosis in transplanted tissue. It has been shown that CD8 positive cells alone are sufficient for the mediation of acute allograft rejection, but with the help of CD4 positive cytokine secretion such as IL-2, colon expansion, and expression of cytotoxic attack molecule will be upregulated as well. So in terms of clinical, as I said, most of the time rejections, acute rejection can be treated. They may need excessive immunosuppression, but they will rarely lead to graft loss as such, unless they're not been adequately treated. So clinical finding most of the time will be absent in mild acute rejection. It will be just derangement of liver function test. And previously people used to put T tubes commonly in bile ducts, and that was one of the markers to see the quality of bile will actually tell you whether the liver is working or not, or whether there is an episode of rejection. Occasionally they may develop ascites because of liver swelling, increase in intrahepatic pressure, and increased production of lymphatic fluid as well. So liver dysfunction usually manifests elevation of some of the standard liver tests, including bilirubin or transaminitis, and there can be peripheral blood leukocytes and eosinophilia are also frequently present. So it is most of the time the diagnosis based on any clinical ground, and it is confirmed with core-needle biopsy. And biopsy, we all know there are defined histological criteria to classify rejections, especially acute rejection, and there is a grading system as well, which is called as BNAF grading system, and it is based on basically mixed but predominantly mononuclear portal inflammation containing blastic or activated lymphocyte, neutrophils, and eosinophil. Then the subendothelial inflammation of portal and or terminal hepatic venules, and then there will be bile duct damage depending on the severity of the rejection. So this is mild rejection, this is moderate, and this is severe rejection. So this is basically depending on the type of rejection, the inflammation will be dependent on that. Then coming to chronic rejection, this is mainly occurs months to years. It is characterized by vasculopathy, fibrosis, and progressive loss of organ function. There are multiple factors, antibodies as well as lymphocytes. Chronic rejection may be mediated by a low-grade persistent delayed hypersensitivity response in which activated macrophages secrete mesenchymal cell growth factors. So chronic rejection may also reflect chronic ischemia. Actually, it is a sort of vasculopathy rather than a rejection per se. Secondary to vascular injury to the blood vessel, which is mediated by antibody or cell-mediated mechanism. So it leads to vascular occlusion, and actually then it will lead to bile duct damage as well. So chronic rejection is characterized by ductal loss. So there will be, although the architecture of the liver will be maintained, but the ducts will be lost because of the ischemic cholangiopathy which happens along with the chronic rejection. So this is just histological features, how the ducts get lost within the portal tract. So the key question comes is, once we know that how the rejection plays a part in liver transplantation. So AMR is rare, but chronic AMR can be there in the liver. Acute rejections can be treated by You just have to be actually, if you are good in terms of managing immunosuppression, acute rejection events will be rare. Long-term graft loss is rare with acute rejection, and chronic rejection actually happens in 5% of the patient. So one of the key questions come here is whether we can predict rejection. So if we can predict rejection, then we can tackle immunosuppression accordingly, and this can actually sort out lots of problems which the patient can have because of prolonged immunosuppressive therapy. But the problem is we don't have those markers. So people have investigated quite a lot, and a lot of research has been done, but at this stage we don't have defined markers to predict rejection, and that's where the problem arises actually. So these are the markers which have been explored. There are quite a few of them which have been assessed in various settings, but none of them actually have been found to be good for prediction of rejection. So I'm not going to go through all this list, but the important ones are, one is the HLA matching, which is very commonly done in other organ transplants, especially in kidney. And it has been shown that HLA matching actually doesn't really impact on clinical outcome in terms of patient and graft survival in the long term. But simultaneously, there is data from smaller centers, especially live donor centers, which have shown that if you have first degree relatives, as when you're receiving graft from your first degree relatives, then the chances of rejection happening is less. And that may be one of the reasons, might be because of the HLA matching. But we don't have confirmed data. So at this stage, HLA matching, to predict rejection based on HLA matching, we can't say that, and we can't deny transplant because of HLA mismatch as well. Because irrespective of HLA mismatch, liver transplant, liver graft works very well. Then there are donor-derived antigens, DSA, which have been explored quite a lot as well. And these are basically, so you look into the blood, and if you have the DSA will come within hours of transplantation into the recipient blood, and the levels of DSA over the longer time can actually reflect on whether the patient is going to develop rejection or not. So there have been studies which have shown they might predict rejection, but then there are studies which have shown that DSA might be there, but then they don't really actually impact in terms of graft function or long-term survival as well. So then the third thing which have been explored recently and it's been found to predict rejection is microRNAs. There's quite a lot of work done on this, and there have been quite a few good papers coming as well. And these microRNAs actually it has been shown that they can predict rejection 40 days before the episode of rejection happen. And but again, the results from various centers are variable. Then the problem with this is, again, to do them so frequently, whether it is possible to do them in such a frequent way and to become as a routine clinical practice is difficult to say. So that's where we are in terms of biomarkers predicting rejection. So one of the things which in terms of coming to basic was eosinophil count. We all know eosinophil count will rise with any immunological episode happens in the body, and there have been quite a lot of studies on eosinophilic count and also looking at eosinophilic granules as well. And some of this data has shown that a rise in eosinophil count or a high eosinophil count may predict rejection as well. But one of the limitations is it happens only when the episode of rejection has happened. So it can't predict beforehand. So it's not like eosinophil count will rise days before the rejection happens. So that's one of the limitations. You may find eosinophil count rise during the episode of rejection, not before. So that's the limitation of that thing. Then there's another marker which is IL-2R expression in peripheral blood leukocytes, which has been identified as potential and a promising marker for diagnostic accuracy as well in rejection. And there have been levels of this which have been studies which in terms of cutoff levels, whether they can predict rejection or not. This is again an early data, but it has got a potential. again use in routine clinical practice is questionable here as well. So actually I have already talked, DSAs I have talked about, and microRNAs I have talked. So now coming to tolerance. So this is what the rejection story is so far in liver transplantation. Then we move on to tolerance in terms of now we know that liver grafts can survive on lesser immunosuppression. And can we come to a point where we actually over the years we can come down on immunosuppression so much, or we can stop them completely and the liver graft will function. So that's where we call it as tolerance. So tolerance is defined as absence of an immune response towards a specific antigen in this absence of immunosuppression. An animal is formally proven to be tolerant when in the absence of immunosuppression, a second graft from the same donor is accepted, while a third graft from a different recipient is rejected. Okay. So in clinical organ transplantation, the surrogate definition is called as operation tolerance. So we don't use definition as a tolerance. We always call it as operational tolerance because this is based on looking at the picture over the time and how things will go. That's why it is called as operational tolerance. And operational tolerance is defined as absence of graft rejection without the use of immunosuppressive drugs. So where this concept comes from? So again, lifelong, it is considered in organ transplantation that you will need lifelong immunosuppressive therapy. And but as I said, even in individuals with absence of immunosuppression are very rare, but have been described in 4 clinical settings. One is patient, they don't take the immunosuppression, and because of that, this happens in kids very commonly as they grow. They stop the immunosuppression because they are non-compliant, and then over the time, it is realized that they've been for a long time without immunosuppression and they have become tolerant. So that's where actually most of the tolerant data comes from. Then immunosuppression might have been stopped because of other things like they develop viral recurrences or they develop cancer. So it's very common for immunosuppression to stop during those episodes, and again it has been seen that the liver is still tolerant. Then obviously when patients have participated in immunosuppression weaning studies, and as I said back, that kidney transplant recipient have been treated with tolerance induction protocol including mixed chimerism strategies. So that's where some of the data, kidney data, is actually there is a huge data on kidney transplant intolerance as well with induction protocols. So coming back to tolerance and liver transplant, as I said before and I showed you, liver has an inherent tolerating properties, and in some species actually you can perform liver transplant without immunosuppression. So in pigs and rats, they don't need immunosuppression. You can perform liver transplantation without that. So that's because of the tolerogenicity of the liver, and that's because dependent on the dendritic cell and T-reg cell. So in human studies, some recipients were completely weaned off of immunosuppression without rejection. And as I said before, when liver transplant is performed simultaneously with other organs, liver acts as a protection to the kidney and to the heart or to the lungs. That is well-known phenomenon, and it is well documented in the literature. There is something more interesting as well, that in kidney transplant, it's very common to get rejection. And there have been actually cases where people have done transplant, part of liver being transplanted in order to protect the kidney. So patients who had multiple kidney transplant and still rejecting, so you can transplant a part of liver and that will actually protect the kidney as well. So that's a very interesting thing, and how far liver actually goes in terms of protecting or tolerogenicity of the liver. So what are the predictors of successful immunosuppression withdrawal in liver transplantation? So there have been quite a few defined in terms of clinical predictors, that is age at transplantation. So younger the age, actually there are higher chances that they become tolerogenic and they may go off immunosuppression. Sex, again, male sex somehow, I don't know why, have more tolerogenicity than female sex here, which is actually quite normally you will have thought the other way around, but in terms of liver transplantation, male sex seems to be higher tolerogenicity. Time since liver transplantation, so greater the interval, so as the time goes on, and they are many years from transplantation, then again they have a higher tolerogenicity capacity, and they may actually come off from immunosuppression. Then what are the cellular and molecular predictors? So they can be flow cytometric immune cell subsets like peripheral blood mononuclear cell, CD4 T-reg cells actually. And then there can be liver tissues, within the liver tissues cells, again T-regs and dendritic cells as well. Then there can be transcriptional profiling, peripheral blood mononuclear cells, microRNAs, FOXP3, natural killer cells, and liver tissue gene expression signatures. So various genes actually can be looked into in terms of, these are the defined ones which are put in here, and they can actually predict whether a particular patient will be tolerant or not. Then there are histological predictors of tolerance like C4D score, a lower total C4D score associated with successful drug withdrawal, and then infiltrating CD45 leukocyte and leukocyte antigen presenting cell pairs within the histology. Again, low inflammatory infiltrate will predict successful drug withdrawal as well. So what are the protocols which have been developed? So there have been a lot of research going on, and various centers have been coming up with lots of protocols. And there have been two multi-center trials which are there. One is left and other is the optimal trial. So basically all these protocols actually run on a very sort of a, it's got a same mapping actually. So you have a patient many years following transplant. You do a baseline liver biopsy and see whether they got ongoing inflammatory activity or rejection episodes or not. And then you gradually start withdrawing the immunosuppression, and then see, you keep doing protocol biopsies in those livers and see whether they got any inflammatory activity or rejection episodes coming. Obviously you monitor clinically as well, and if over the years they remain stable liver function with biopsy also not showing changes, then they are actually, so 2 years, if you are following 2 years from the initial protocol, if you are free of rejection or biopsy is still normal, you will be classified into a tolerant group as well. Then there is so most of these protocols are based on what I'll say is learning and erring and learning. So you basically starting on a normal point, and then you start going and see where we will go. So what we've seen in this protocols is maybe around 50% of this patient will drop out because of some or other reason, because they will have episodes of rejection or biopsy will show changes, and only maybe 30-40% actually might actually reach where the immunosuppression can be completely withdrawn, and that is in a very selected group of patient, highly selected group of patient. So then it comes to whether we can change those protocol, and we do it more scientifically in terms of whether we use the tolerant signature, and then depending on those signature we select out the patient who should be put into a protocol and who should not be put into a protocol. So this is again one of the trials which have been the left trial, which is based on basically looking at tolerogenic signals before starting on to putting them into the protocol, and if they have tolerant signature, then they will go on immunosuppression withdrawal protocol. If they don't, they will not be taken up for the immunosuppression withdrawal protocol. That looks more scientific approach, and also it doesn't risk in terms of sometime rejection, if it is not treated, can lead to graft loss and patient will have problem as well. So that looks more scientific. So what are the potential biomarkers of tolerance? These are the ones which have been used in left protocol. So the cytokines, that is IL-4 down regulation, increase intrahepatic transcript levels of PD1, pyruvate formulate lyase 1, and suppressor of cytokine signaling 1 as well. Then there are genes which have been used, microRNA 146A, microRNA 15B, microRNA 223 upregulation, then lectin galactose binding soluble 1, fibrinogen-like protein 1. So these are the ones which are being used, which have been identified from animal models and now being used into the human trials in terms of predicting tolerogenicity. And so as I said before, Actually, when you map out all these things, actually come down to Treg. Somehow it all comes down to two particular things. One is dendritic cell and Treg cell, and there have been quite a lot of interest on studying Treg cell. So this is one of the papers which was published on microRNA and Treg subset, and this were 44 patients from multicenter. It's a multicenter study as well, and which were taken onto the tolerance protocol. And a higher Treg cells and TSDR demethylation rate was seen in tolerant group. So if you have Treg cell activity going on, then there is a very good chance that you may become tolerant, and that is considered to be very good predictors if right from the start of the transplantation. So we had an interest in this as well, and we thought we will do some work in terms of kinetics of regulatory T cells in live donor liver transplantation, and to see how Tregs behave in LDLTs, because early on in the course, not late on or not years on to, because one of the things which live donor liver transplantation is, there is very minimal ischemia reperfusion injury, and in cadaveric transplant, because of ischemia reperfusion injury, there is a lot of overlap, and it's very difficult to understand what is happening because of ischemia reperfusion and what is happening as a normal process of rejection. So we tried to look into it, and in terms of frequency and functionality of Tregs during the course of engraftment of LDLT. So this were 33 patients with various etiologies. Predominant obviously was alcohol, but there were virus as well, and some of them had hepatocellular cancers as well. And this was just their operative profile. So in terms of ACR, so one episode of ACR was seen in 24% of this patient. This was clinical ACR. 2 episodes were seen in 9% of the patient, and total number of patients with clinical ACR in first 3 months were 33% with us. And out of this, actually only 15% needed steroid pulsing, and the median day to ACR was 13 days. Median day to clinical ACR after first month was around 60 days, and out of this only biopsy proven was in 5%. Obviously some of them didn't have a biopsy because early on in the course we don't like to do biopsy. We had problems in terms of bleeding and all those things. They all had good tacrolimus level maintained initially, and so what we found was at pre-transplant time point, when we look at the CD4 positive, CD25 positive FOX3 positive Treg was significantly increased in pre-transplant patients compared to healthy donors. So there was a significantly increased levels of Tregs when we compare with the healthy donors. However, the CD425, the FOX3 Tregs actually, number and IL-10 and IL-17 and TGF-beta secreting functioning Treg were significantly decreased at 3 months compared to pre-transplant. So there was, after 3 months of transplant, the Tregs were decreased significantly from what it was from pre-transplant level. Then again, when we compared between rejection and non-rejection, so again the CD4 positive, CD25 positive FOXP3 and CD4 positive, CD25 positive, CD127 Tregs were significantly decreased much before day 3 compared to non-rejection. So in the rejector group, the T cell activity, Tregs activity was not maintained, and that may be one of the reasons why they had episodes of rejection. Then again, comparing rejection versus non-rejection, then the IL-17 and TGF-beta secreting Tregs at pre-transplant showed significantly decreased compared to no rejection group. So that again, it means down regulation of IL-6 and TGF-beta was seen as well in no rejection group. And then rejectors had decreased CD45 RA positive CRR7 terminally differentiated, that is Stembra cells, at pre-transplant and 7 days as well. So these are terminally effector memory CD4 cells, which I initially told are the cytotoxic ones, which will lead to cell death as well. So that they So when we compare with them with the rejectors and non-rejectors, so they are more in rejectors. Okay. Then coming to central memory cells were decreased at pre-transplant 1 month and 3 to 6 months as well. So again comparing rejections versus non-rejection as well. So what we concluded from that study was moderate immunosuppression, lesser schema reperfusion injury in LDLT helped to preserve T-reg frequency in early post-transplant period, while higher T-reg frequency and priming help by preventing allograft rejection. So T-cell subpopulation like TEMRA and CM may guide prediction of rejection in early post-transplant period. So this was work done by Ankur, Rashi, and Nirupama obviously was the supervisor of this work as well. And it's a great start for us. So we know we can do something like that in terms of tolerance as well. So now coming to the last bit. So how can we, I talked about all this tolerance protocol, and they all talk about years after transplantation. And what will happen when you do all this years after transplantation, that already the side effects of immunosuppressive therapy has happened, and patients have developed metabolic syndromes, and they may not reverse. And we've seen that once they gain weight and all those things, once they develop diabetes, hypertension, then most of these patients actually will develop problems and they may not reverse. So, you may achieve tolerance, but the goal of having a patient not having a side effects of immunosuppression is still not there. So what can we do in order to not have that situation? Can we do something different? Can we come up with something new ideas? And that's where a lot of attention is going on in terms of cell therapy to promote tolerance. And these are the ones which are being used, third-party mesenchymal stromal cells. They've been shown to be, at this stage, what we know is they don't cause harm, but we don't know whether they can promote tolerance or not. Then multipotent adult progenitor cells, again, is at the same level. It has been shown that they cause no harm, but still we don't know whether the long-term tolerance can be happen. Donor-derived stem cells and donor-derived regulatory dendritic cell and T-reg. These are the three which have been studied extensively, and they are part of many multi-center protocols which are there, where especially in live donor liver transplantation, because live donor liver transplantation is a timed operation, it is an elective operation unless it's an emergency, and so in those patients you can actually give them before the transplant, and that can actually promote tolerogenicity, and that can then in those situations you can take them off immunosuppression within months after transplant. So these are three which are being used extensively in multi-center trial, and they will actually become part of routine practice in coming years. So there is enough actually development happening, and with the advent of artificial intelligence as well, this will become actually part of routine practice in years to come, where you will going to give the cells before transplant and maybe to promote tolerance, and then take them off immunosuppression within months of transplant. So we've been trying to put up a protocol. This has been in the pipeline for last year or so. So what we thought was we will start with longer term, that is 3 years after transplant, in patients who have freedom from rejection for at least 12 months and in low immunosuppressive, preferably single agent, with a persistently normal LFTs at 6 months. Obviously, these are the excluding criteria: autoimmune, acute viral hepatitis, ongoing biliary tissues, patient with recidivism, and patients on sirolimus or everolimus. And these are the baseline assessment which we plan to do. That will be obviously liver function test and liver biopsy. Then obviously extensive immunological assay in terms of dendritic cells, monocyte, classical and non-classical, then T-reg cells, NK cells, and B memory cells, plasma cells as well. Then mass cytometry, microRNAs on the liver tissue and urine and proteomics as well. And to find out whether in live donor transplantation we can predict rejection or not. And obviously this is the follow-up protocol for this patient. So do LFTs every 7 days for first month, then 15 days for 3 months, then monthly for 6 months, and 6 weeklies for 2 years, and obviously to do a protocol biopsies as well. Then another thing will be to develop donor-derived stem cells and donor-derived regulated dendritic cell and T-reg cells, which we can use in a pre-transplant setting in order to get tolerogenicity. So that's the areas we think we should be doing work on, and that's where liver transplantation is heading as well. So take home, in the clinic, dramatic improvement in liver transplant outcome were made possible by advent of potent and selective immunosuppressive drugs. And to further prolong patient survival, to avoid immunosuppression related adverse event, and to maintain good quality of life, minimization if not complete withdrawal of this agent is the key. In the setting of clinical liver transplant, a substantial subset of graft recipient are found to be operationally tolerant after immunosuppression withdrawal. And the current tolerance protocol involves long periods between transplantation and initiation of immunosuppression withdrawal. The clinical benefit of stopping immunosuppression drugs at this later stage may not be the goal, because it won't achieve what we want to be, not having side effects of immunosuppression. We need reliable biomarkers to detect tolerance and subclinical rejection, as well to understand the mechanism that underpin clinical tolerance. Early phase clinical trials on regulatory immune cells have shown promising results. The implementation of this novel approaches to modulate host alloimmune responses in combination with above mentioned biomarkers will hopefully enable minimization and complete withdrawal of immunosuppression. So my acknowledgements to Nirupama, Ankur, Rashi, Bharat, who helped with the slides as well. I'm sure a lot of people will have a lot of questions, but I need a few more minutes, and I think it's very important. So what we've done this week, we completed 101 pediatric liver transplants. It's a massive achievement for ILBS. Big thing, very big thing actually. So to come up to this 101 pediatric liver transplant is a very big thing, and we've done in a way which is unique, because if we see, we've done about 750 total transplants, out of which 101 is pediatric. So that takes us 15% of our activity as pediatric, which if we compare with centers in the world who started liver transplant program, the activity will be around 5% or so. And to do this within first 1,000 to have an activity of 15% is a big achievement. Then one of the things is obviously most of these have been live donor liver transplant, 6 of them have been DDLT, we've done EBA incompatible as well. But there's a high proportion of ALF. So out of this, 40% is acute liver failure. So this is rare. This doesn't happen anywhere in the world, that to transplant such a high number of acute liver failure, 40% of ALF pediatric liver transplant, which is very high. If you see any other centers data worldwide, 5%, 10% maximum, that will be there. So this have been the etiologies. Again, ALF has been the predominant etiologies for us. I won't go into details. This is just our outcome data. In CLD we've done 84%, and in acute liver failure we are 75%. So this is where we are, and this is a huge achievement.